Good afternoon, everybody. It's a pleasure and a privilege to be here. I want to start by thanking all of you for taking the time to be here. I want to thank CVRX for sponsoring this event. And I want to thank our phenomenal faculty, Dr. Allred and Dr. Vadim, who will be participating in today's symposium, really elaborating on the new technology of Barostim. We're going to break this session up into three parts. I'm going to talk about how we got here. Dr. Vadim will talk about where are we right now. And Dr. Allred will tell us some things about where we are potentially going in the future. So it's going to be really an interesting symposium, and I hope there's a lot to glean from it. So let me start by really setting the stage for device therapy for HFrEF, or heart failure with reduced ejection fraction. There are many forms of treating patients with heart failure with reduced ejection fraction beyond guideline medical therapy. And we know many of these patients have associated moderate mitral regurgitation, that may require transcatheter repair. They may have atrial fibrillation that may require associated ablations. Many of them have a wide QRS and do really well with cardiac resynchronization therapy, but there's this whole subset of patients with HFrEF where CRT doesn't really work that well. And if you look at the subset of patients with heart failure with reduced ejection fraction, it's a large number, and only 30% of those patients actually are eligible for cardiac resynchronization therapy. 70% of those patients either have a non-left bundle branch block that is less than 150 milliseconds or have a narrow QRS that really don't make them eligible for cardiac resynchronization therapy. So we're very excited by the potential of some of the newer strategies that can help us manage this subset of patients out here. So how has device therapy really evolved over the years? So this goes back several years. I think, it is in 1985 that the first ICD was approved, which I think we all know that Dr. Morawski and Dr. Maurer really kind of created that new paradigm for how we treat patients with sudden cardiac arrest. It was subsequently in 1996 that after a slew of studies that ICDs then got approved for primary prevention. And then we had, in 2002, we had cardiac resynchronization therapy, which was developed, which is largely to treat patients who had a wide QRS, who had evidence of electrical and mechanical desynchrony, where CRT was able to change the course of their lives. Now, over the course of the next 17 years or so, there's been a lot of progress, a lot of studies, and since cardiac resynchronization therapy works so well, it was tried in patients with narrow QRS. So as you know, there was this slew of studies with narrow QRS who had associated mechanical desynchrony, which was elicited by echocardiography, and whether it was the RETHINK study or the Lesser Earth study or the Echo CRT study or the narrow QRS study, all of them were actually neutral to negative for resynchronization therapy. In fact, the Echo CRT study, which I had the honor or notoriety of co-leading, actually saw that CRT increased mortality in patients who had a narrow QRS with heart failure. This then brought in the realm of autonomic modulation. And that brought in spinal cord stimulation, which we know was defeated by the DEFEAT study, which really showed that spinal cord stimulation does not help patients with heart failure. And then we had a slew of studies looking at vagal nerve stimulation. This is the NECTAR-HF study and the INNOVATE-HF study. Again, both of them being neutral studies, and obviously we're waiting for the HFrEF study, which hopefully will have its results in the next year or so. But really, vagal nerve stimulation has not panned out for treating this patient's population with heart failure. And this brings us to Baroreflex Activation Therapy. Now, this is a therapy, as we know, has been FDA approved in 2019 for patients with an ejection fraction of less than 35%, class 3 NYHA on optimal medical therapy. This therapy basically involves putting an electrode over the carotid bifurcation, connected to a little device, and stimulation of the device changes the sympathovagal balance. It increases the parasympathetic tone, it decreases the sympathetic tone, it reduces heart rate, and at the same time causes natriuresis and diuresis and actually translates into better outcomes for heart failure. There is this whole spectrum of autonomic studies that potentially could be done, but of these different areas, whether it's the tragus, the vagus, renal denervation, or intrinsic cardiac autonomic ganglia ablation or stimulation, the only one that has panned out so far is Baroreflex Activation Therapy out here. So I'm really excited about the potential for this field. And with that, I'm going to pass on the mantle out here to Dr. Fudeem. And let me get the slides set up for him.